Welcome. You're looking for the high-yield stuff, the core knowledge without the fluff. And today, we're really zeroing in on kidney problems. Specifically that fundamental question, is the kidney losing mainly protein or is it losing blood? Proteinuria versus hematuria.
Exactly. We're cutting through the complexity today.
So the idea is to pull out those key differences, maybe some surprising details, the things that really make it click.
That's the plan. And really, at the broadest level, these kidney issues often fall into two main buckets. It's like a fork in the road.
Okay.
One path is where you get excessive protein leaking out. That's what we call nephrotic syndrome. The other path is where blood is the primary thing showing up in the urine nephritic syndrome. And they look, well, quite different clinically.
Right. Let's start with nephrotic syndrome then. What are the classic signs? If someone has this, what are we seeing?
So clinically, nephrotic syndrome usually has four kind of cardinal features. First, really high levels of protein in the urine, significant proteinuria.
All right, lots of protein lost.
Which then leads to the second feature, low protein levels in the blood, hypoproteinemia.
Makes sense. If it's leaving, it's low in the blood.
Precisely. And because those proteins, especially albumin, help keep fluid inside our blood vessels, oncotic pressure, losing them, causes fluid to leak into tissues. That's the third feature. Edema or swelling.
So that's the direct link to the swelling.
Yes. And fourth, we often see high levels of lipids, particularly LDL cholesterol in the blood, hyperlipidemia.
Interesting. Why the high cholesterol?
It's thought to be linked to the liver trying to compensate for the low protein by ramping up production of various things, including lipoproteins. It's a bit complex, but it's a common finding.
Got it. So protein loss triggers this cascade.
Right.
Low blood protein, swelling, high cholesterol. Anything else clinically important with nephrotic?
Yeah, a couple of other risks come with it. Losing proteins, including antibodies, can increase the risk of infections.
Weakened defenses.
And losing certain anticoagulant proteins, combined with other factors, bumps up the risk of blood clots, thrombosis.
Okay, so not just the main four signs, but risks of infection and clots too. Now let's switch gears. What about nephritic syndrome? How does that present?
Nephritic syndrome paints a more inflammatory picture. The key features are different. You often see high blood pressure, hypertension.
Right.
Then the defining feature, hematuria, blood in the urine. Sometimes it's visible, sometimes only microscopic.
Blood, okay.
You might also see signs of fluid overload, like jugular venous distension. The neck veins look full.
Fluid backing up.
Yeah. And related to that, sometimes reduced urine output, oliguria. There can be some edema, but usually it's milder than in nephrotic syndrome.
Less traumatic swelling.
Typically, yes. And while protein loss is the hallmark of nephrotic, you can get some proteinuria in nephritic syndrome too, just usually less severe.
Okay.
And finally, because the kidney function itself is often acutely impaired, you get a buildup of waste products in the blood, what we call interrenal azotemia.
So a picture of inflammation, blood loss, blood pressure issues, and kidney function taking a hit. Now let's go deeper. What's happening inside the kidney? What do these look like under the microscope, starting with the nephrotic types?
Right, so when we look at kidney biopsies for nephrotic syndrome, pathologists identify several main patterns or subtypes. The big ones are minimal change disease, focal segmental glomerulosclerosis, FSGS, for short membranous nephropathy, diabetic nephropathy, and amyloid nephropathy.
Okay, 5 main types. Let's take minimal change disease first. The name sounds minor.
It does, and in some ways it is, relatively speaking. It's most common in younger kids. They get significant proteinuria, but the amazing thing is it usually responds incredibly well to steroids, like magic sometimes.
Really? Steroids just fix it?
Often, yes. The prognosis is generally excellent. Interestingly, there's a rare association with Hodgkin's lymphoma. A key feature is selective proteinuria. Mostly just albumin gets through, not the larger proteins. And under a standard light microscope, the kidney tissue often looks, well, normal or minimally changed.
Hence the name. So where's the problem?
You need an electron microscope to see it. There, you find that the little foot processes of the podocyte's specialized cells wrapping the capillaries are flattened or effaced. That's the hallmark. The onset and recovery can be quite abrupt.
Effaced podocytes. Got it.
Okay.
Okay, next. Focal segmental glomerulosclerosis, FSGS. Sounds more serious.
It generally is. Tends to affect older individuals, though it can occur at any age. It's often more severe, progresses more often, and responds less reliably to steroids than minimal change disease.
So tougher to treat.
Yes. It can happen on its own or be secondary to things like HIV infection, heroin use, parvovirus B19, or even follow other kidney diseases like IgA nephropathy.
Wider range of causes or associations.
Right. And unlike minimal change, you might see some microscopic blood in the urine, and the protein loss is non-selective. Bigger proteins get through too. It tends to creep up more gradually.
And under the microscope, focal and segmental. What does that mean?
It means the scarring, the sclerosis, only affects some of the glomeruli, that's the focal part, and only parts of those affected glomeruli, that's the segmental part. You also see hyalinosis, a glassy material, and sometimes foamy-looking cells full of lipids. Electron microscopy still shows that podocyte effacement, though.
Okay, so actual scarring in parts of the filters. Moving on to membranous nephropathy.
This is a very common cause of nephrotic syndrome in adults, maybe the most common primary cause in some populations. Patients might have hematuria along with the proteinuria, and they have a particularly high risk of thrombosis, those blood clots we mentioned.
Higher risk of clots here. What's the look?
On light microscopy, the main thing is diffuse thickening of the capillary walls in the glomeruli. But the really characteristic finding is on electron microscopy.
What's that?
You see immune complex deposits underneath the podocytes on the outer side of the basement membrane, subepithelial deposits. When stained, these can create a spikes and domes appearance.
Spikes and domes. Very visual.
Yeah.
Immune complexes. So the immune system is involved.
Yes. It can be primary, linked to antibodies against a receptor on podocytes called PLA2R, or it can be secondary to other things, infections like syphilis, hepatitis B or C, malaria, certain cancers, autoimmune diseases like lupus, and the protein loss is non-selective.
Lots of potential triggers.
Yeah.
Okay, next up, diabetic nephropathy. I imagine this is linked to diabetes.
Absolutely. This is a major complication of diabetes, both type 1 and type 2, especially if it's been present for a long time, usually over 10 years, and maybe not tightly controlled. High blood pressure is a big risk factor, too.
So long-term effect.
Yes, and it's usually a slow, gradual progression. It starts with tiny amounts of albumin in the urine, microalbuminuria, which can then worsen over years into full-blown nephrotic syndrome.
And the microscopic findings.
They're quite characteristic. You see thickening of the glomerular basement membrane, hardening of the small arteries feeding the glomerulus, arteriolosclerosis, and these distinctive pink spherical nodules called Kimmel-Steele-Wilson nodules.
Kimmel-Steele-Wilson nodules. That's the buzzword for diabetic kidney disease, right?
It's a classic finding, yes. You can also see more diffuse scarring and sometimes damage to other kidney structures. Podocytes often show effacement, too. Importantly, medications like ACE inhibitors or ARBs can help slow the progression.
Good to know there's treatment that helps. All right, last one in the nephrotic category. Amyloid nephropathy. What's amyloid?
Amyloid refers to abnormal proteins that fold incorrectly and then aggregate, forming insoluble fibrils that deposit in tissues. This can happen in various conditions.
Like what?
Well, primary amyloidosis is often linked to plasma cell disorders like multiple myeloma. Secondary amyloidosis can occur with chronic inflammatory conditions like rheumatoid arthritis or chronic infections. The kidney is actually the most common organ affected by amyloid deposition.
So the kidney gets clogged up with this stuff.
Pretty much. The diagnosis involves figuring out the underlying cause of the amyloid and then confirming the amyloid deposits in the kidney, usually with a biopsy. Amyloid stains with Congo red and shows a characteristic apple-green birefringence under polarized light. Deposits can be in the glomeruli, blood vessels, interstitium.
And the outcome?
It really depends on the underlying condition causing the amyloidosis and how well that can be treated. Managing the primary disease is key.
Okay, that covers the main nephrotic types. Now, you mentioned some conditions that kind of straddle the line, showing features of both nephrotic and nephritic syndromes. The diffuses, was it?
Well, maybe overlap syndromes is more formal. But yes, there are conditions where the picture is mixed. The two big examples are diffuse proliferative glomerulonephritis, or DPGN, and membranoproliferative glomerulonephritis, MPGN.
Let's start with DPGN. Where does the overlap come in?
DPGN is a major one, particularly because it's the most common and often most severe form of kidney involvement in lupus nephritis.
Lupus again.
Yes. Patients typically have hypertension, hematuria, that's nephritic, and significant proteinuria, that's nephrotic. Under the microscope, the glomeruli are hypercellular, inflamed, often with immune cells packed in. You might see wire loop lesions, which are thickened capillary walls due to immune deposits and sometimes even small clots.
Sounds quite severe. What about the immune deposits?
Using electron microscopy and immunofluorescence staining, you see granular immune complex deposits located under the endothelial cells lining the capillary subendothelial deposits.
subendothelial this time.
Yeah.
And treatment.
Usually requires aggressive immunosuppression. Unfortunately, DPGN can progress quite rapidly, sometimes leading to rapidly progressive glomerulonephritis, chronic kidney disease, and eventual kidney failure.
A serious diagnosis.
Okay, what about the other overlap one? Membranoproliferative glomerulonephritis, MPGN.
Right, MPGN is a bit complicated because it has subtypes, primarily type 1 and type 2. Both can present with features of either nephrotic or nephritic syndrome, or a mix.
Okay, tack one first.
MPGN type 1 also involves immune complex deposits in the subendothelial space, similar to DPGN. A characteristic feature on light microscopy is a tram track appearance of the glomerular basement membrane.
Yeah, it looks like the basement membrane is split into two layers, like railway tracks, because cells are growing into that subendothelial space where the deposits are. Type 1 is often associated with chronic infections like hepatitis C or B, or conditions like cryoglobulinemia. It tends to lead to chronic kidney disease.
Okay. And MPGN type 2.
Type 2 is now often called dense deposit disease. Here, the deposits are actually within the glomerular basement membrane itself, making it look very thick and dense on electron microscopy. It can also have a tram track appearance sometimes.
So deposits in the membrane, not under it.
Exactly. Type 2 is often associated with abnormalities in the complement system, specifically something called C3 nephritic factor, leading to low complement levels in the blood. Like type 1, it also frequently progresses to chronic kidney disease. Management for both types often involves treating any underlying condition and immunosuppression.
So these overlap syndromes are often progressive and challenging. Let's pivot now fully to the primarily nephritic conditions.
Yeah.
What are the main culprits we see on biopsy there?
For the primarily nephritic picture, the key histopathological diagnoses we think about are acute post-streptococcal glomerulonephritis, rapidly progressive glomerulonephritis, RPGN, IgA nephropathy, and Alport syndrome.
Acute post-streptococcal GN. Sounds like it happens after a strep infection.
Precisely. It's the classic example of a post-infectious glomerulonephritis, most common in children. Typically, there's a history of strep throat or a skin infection like impetigo about, say, 2 to 3 weeks before the kidney symptoms start.
What are the symptoms?
Classic nephritic signs: hematuria, often cola-colored urine, hypertension, some proteinuria, maybe fever and edema characteristically, puffiness around the eyes, periorbital edema.
That eye puffiness is a clue.
It's quite suggestive, yeah. Diagnosis leans on that history, the symptoms, and lab tests showing evidence of recent strep infection, like elevated anti-streptolysin O, ASO, titers after throat infections, or anti-DNase B antibodies after skin infections.
And the biopsy
shows diffusely inflamed hypercellular glomeruli, often packed with neutrophils early on. Immunofluorescence and EM show granule immune complex deposits, but this time they are typically subepithelial, like in Membranous, but the context is different.
Subepithelial again. How's it treated?
Usually with antibiotics like penicillin to eradicate any lingering strep and supportive care for blood pressure and fluid balance. The good news is, especially in children, the prognosis is generally excellent with full recovery.
Okay, so usually resolves well in kids. Now, rapidly progressive glomerulonephritis, RPGN. The name sounds ominous.
It is. This is a clinical syndrome defined by rapid loss of kidney function. We're talking decline over days to weeks, leading towards kidney failure. It's a medical emergency.
Days to weeks. Wow, what's the defining feature microscopically?
The absolute hallmark is the presence of crescents in Bowman's space, the area surrounding the glomerulus. These crescents are formed by proliferating cells and inflammatory infiltrate. Seeing crescents is a sign of severe glomerular injury.
Crescent's bad news. How is RPGN classified?
It's typically classified based on immunofluorescence findings. Type 1 shows linear deposits of antibodies along the basement membrane. This is seen in Goodpasture syndrome, where antibodies attack both the kidney and lung basement membranes.
Linear pattern for Goodpastures.
Type 2 shows granular immune complex deposition, like we see in severe post-streptococcal GN or lupus nephritis when they progress rapidly.
Granular pattern like in lupus or post-strep.
And type 3 is Pulci immune RPGN. Pulci means few. Here, there are few or no immune deposits seen. This type is most often associated with ANCA-associated vasculitis, systemic inflammation of blood vessels, like granulomatosis with polyangiitis, GPA, or microscopic polyangiitis, MPA.
Pulci immune linked to vasculitis. How do you treat RPGN?
aggressively. Treatment targets the underlying cause like plasmapheresis to remove antibodies in good pastures or strong immunosuppression for vasculitis or lupus. Despite treatment, the risk of progressing to end-stage kidney disease requiring dialysis or transplant is unfortunately high.
Very serious. Okay, next on the nephritic list, IgA nephropathy.
Also known as Berger disease. This is actually the most common type of primary glomerulonephritis worldwide. A classic presentation, though not universal, is episodes of visible hematuria occurring concurrently with or just a day or two after an upper respiratory tract infection, like pharyngitis.
So blood in the urine,
Yeah.
right, with the sore throat, not weeks later like post-strep.
Exactly. That timing is a key difference. Patients can also have hypertension, microscopic hematuria between episodes, and variable proteinuria. Lab-wise, serum IgA levels are often elevated.
And the biopsy confirms it.
Yes. The defining feature is deposition of IgA immune complexes predominantly in the mesangium, the central supporting structure of the glomerulus.
IgA in the mesangium. Is this related to anything else?
Yes, there's a very important association with Henoch-Schönlein purpura, or HSP, which is now often called IgA vasculitis. HSP is a systemic vasculitis causing a rash, palpable purpura, joint pain, abdominal pain, and kidney involvement that looks identical to IgA nephropathy on biopsy. You find IgA deposits in the skin biopsy, too.
So IgA nephropathy is like the kidney-limited form of IgA vasculitis HSP.
You can think of it that way, yes. Treatment often involves blood pressure control with ACE inhibitors or ARBs, and sometimes immunosuppressants for more severe or progressive cases. It can lead to chronic kidney disease over time.
Okay, last one for the primarily nephritic group, Alport syndrome.
Alport syndrome is different because it's primarily a genetic disorder, not an immune-mediated one. It's caused by mutations in the genes encoding type V collagen, which is a crucial structural protein in the glomerular basement membrane, as well as in the cochlea of the ear and in the eye.
So a problem with the kidney's building blocks.
Exactly. It's most commonly X-linked, meaning it predominantly affects males more severely. The classic triad of findings is nephritic syndrome, hematuria, proteinuria, progressing towards kidney failure, sensorineural hearing loss, and characteristic eye abnormalities like anterior lenticonus, a conical shape to the lens, or cataracts.
Kidney, ears, and eyes.
Yes.
That's the triad. How was it diagnosed?
Based on the clinical picture, family history, and characteristic findings on electron microscopy of a kidney biopsy. The glomerular basement membrane shows irregular thickening and thinning with splitting and lamination of the lamina densa layer, sometimes described as a basket weave pattern.
Basket weave pattern. Not immune complexes here.
No, this is a structural defect. Unfortunately, it typically progresses to end-stage renal disease, often by young adulthood, requiring dialysis or transplantation.
A tough genetic condition.
Yeah.
So just to quickly recap the immune deposits we talked about, where do they end up? It seems like location matter.
It absolutely does. It's key for diagnosis. So very briefly, membranous nephropathy and post-streptococcal GN typically have subepithelial deposits under the podocytes.
Okay.
Diffuse proliferative GN, like in lupus and MPGN type 1, have subendothelial deposits under the capillary lining cells.
Right.
MPGN type 2 has deposits within the basement membrane itself, intramembranous.
Right.
Good pastures has linear antibodies on the basement membrane, though maybe not bulky deposits. IgA nephropathy has IgA deposits in the mesangium. And Alport syndrome, being genetic, has no immune complex deposition.
That's a really helpful summary of the locations. Well, this has been exactly what we aimed for, a focused, efficient run-through of these key kidney syndromes.
Yeah, I think by sticking to that core question of protein or blood and then layering on the key clinical signs and the defining microscopic features, you get a pretty solid foundation. We've covered the essentials quite quickly.
It definitely highlights how, different starting points, different symptoms can really point towards specific underlying mechanisms within the kidney.
Absolutely.
It makes you wonder, doesn't it? How many other sets of symptoms in the body might link back to equally precise, though maybe unexpected root causes? Something to think about.
Definitely. That connection between symptom patterns and underlying pathophysiology is always fascinating to unravel. A great place to leave off.